And I would request Dr. Saurabh Mondal to introduce Debasmita, who has brought the lady to this state of ours.
I'm not going to
Okay,
Yes,
okay.
now
I was
the-
just joking. Now
the speaker is Dr. Professor Debasmita Mondal. She is attached to EZECHO Hospital and IPGMER.
না না আমি দাঁড়িয়ে আছি
And she's the fetal medicine in charge there. And she also director of the Krishna Institute of Cardiac and Fetal Sciences.
A very good evening to everyone, and it's a very much opportunity for me to be to stood by beside you all cardiologists to speak on some cardiac abnormality, fetal cardiac abnormalities. I'm really thankful to all organizing committee of EZECHO for calling me for this speaking on this fetal cardiac abnormalities. Thank you so much. Yeah, this is all about the nooks and corner of the fetal heart. Actually, these are some kind of fetal heart depiction from the very 12 to 13 weeks heart. We have done the 4D heart, though it was not necessary always, but certain time it can be necessary also to depict any kind of small kind of abnormality or something. So my introduction will be starting with some questions always. I'm always a curious person to be asked some questions to myself as well as to others. Why we are standing here and giving the importance of the fetal echo. What is the incidence of congenital heart disease in India? And how many prenatally diagnosed actually? How many timely detected actually? And timely diagnosis of congenital heart disease impacted the postnatal and prenatal outcome. How many actually? How many managed successfully prenatally or postnatally? Postnatally in India at least. Why prenatal diagnosis of congenital heart disease important actually? Considering the birth prevalence of congenital heart disease as 9 per 1,000, the estimated number of children born with congenital heart disease in India is more than 200,000 per year. It's such a big piled up things are there. Of this, about 1/5 are likely to have serious defect requiring an intervention in the first year of life itself. And congenital heart disease were prenatally detected for at least 50% of the cases. It's a European data. I couldn't get any kind of data from India actually. And prenatal detection was consistently high with the hypoplastic left heart, which can be easily diagnosed in the fourth chamber or something. Who have been doing the fetal echo, initially also they can detect the things, but it was lowest for the total anomalous pulmonary venous written like this. So this also happens actually. So these are the diagnostic dilemmas, like some small soft markers can be associated with cardiac abnormalities. Late evolving cardiac abnormalities may be there. So fetal echo is not finished at 18 to 24 weeks. It can be started with at the age of 32 weeks also. You can see some heart disease anomalies at that moment of things are there. So dysfunctional heart due to the growth complications may be. IUGR baby can have a compensatory heart failure that we can see through the fetal echo. Or a twin transition is happening in the monochorionic twin. So another twin which is affecting actually that can have a abnormal heart also. So these things has to be kept in the mind actually. It is not only structural things actually. Then the incidence of spontaneous VSD closure, we have to take it in mind, because while speaking about the VSD, it is very much important to say about the diameter of the VSD, where it is sitting on the VSD, whether it is subaortic or subpulmonary or it is a muscular, it is very, very important. So these abnormalities has to be spoken in a very right language so that the patient should not come and going for the MTP always. It is not actually the truth actually. So the fetal medicine aspect of congenital heart disease, I am not a pediatrics cardiologist or a cardiologist, but I am an obstetrician practicing fetal medicine. Actually, we are dealing with the prenatal diagnosis and referral in due time, extracardiac malformations we need to consider, and chromosomal aberrations. So extracardiac malformations, so many malformations are there, and chromosomal aberrations are there associated with the cardiac abnormalities. And there are guidelines already, Dr. Debasmita had explained, so I am not going detail about all these things. So we have to see whether the apex in the left side is to levocardia, at least 2 pulmonary veins we can see, not the 4 pulmonary veins, and 2 atria in the similar size, and they have got their own morphological features also. We have to look at that. And the ventricles are also similar kinds of size, and how the offsets are actually opening inside the ventricle, that is also very important. We have to look through. The cursor, the crux of the heart, those things are the things, nooks and corner of the fetal echo that had been explained by the doctor beforehand. So those things has to look around. Even in abnormal heart, we are not jumping about the diagnosis. We have to go through those segmental approach again and again, because diagnosing a normal heart is also difficult. To say it is at 100% normal, that is also difficult actually. So these are the things. So these are the features of the right ventricle, left ventricle, how the atrium behaves. The appendages are different in the left atrium from the right atrium. Left atrium is a posterior structure, but the right atrium is an anterior structure. So many things are there because the isomerism, in isomerism you have to differentiate it out because it may mimic the atriums. The left atrium mimic the right atrium mimic the left atrium. So these are the things. These are already been explained nicely. So I am not going to detail. And so these are the connections. Equal thickness of free ventricular wall, that also matters. Intact ventricular septums matters. And these are the site determination. The situs determination also matters. He has already explained. So these are the actually things has been told. That's the apical heart, basal heart, all things has been explained very nicely. So I am not going to in detail. I am directly going to the all the things actually. So if in a 4-chamber view, if we are looking into the heart, then what are the abnormalities we may actually cross through? That is the right arteriomegaly. It's very simple. Heart is just like a mathematics, how the atrium is behaving, whether it is bigger or smaller. It is the atrium or the ventricle, both the ventricle. If one ventricle is smaller, then it is speaking out something disorder. If the artery is smaller or the artery is bigger, it is going to speak out with something. So that's why right arteriomegaly from tricuspid dysplasia can be very easily diagnosed. Right arteriomegaly from Epstein's anomaly, ventricular septal defects can be looked through the 4-chamber. Atrioventricular septal defects, left ventricular hyperplasia, and right ventricular hyperplasia. And double inlet left ventricle, these are very, very rare. Ventricular disproportion due to the coarctation of aorta, biventricular hypertrophy due to cardiomyopathy, and cardiac tumor. So this is the case, one of the right atrial enlargement. We can see the right atrial enlargement is due to, before switching over the, I can show you the things. So this is the basically posterior leaflets of the tricuspid valve. How much it is posteriorly placed, we can see. So this is the posteriorly positioned, rather it is not dysplastic, rather it is posteriorly positioned, the posterior leaflets of the tricuspid valve. So it is a case of actually Epstein's malformation. That actually differentiates from the tricuspid dysplasia. So this is the how we can see through this atrium as well as the posterior leaflet distance from the crux, we can see how it is increased. So this is about the Epstein's anomaly basically. So the next case we will go. This is another case of Epstein's. How the here the posterior leaflets are also thickened because of the less perfusion of the heart, and we can see the whole thing. And there is endomyocardial fibrosis also there. So this is all about the thing. And another criteria of the Epstein's anomaly, the tricuspid regurgitation. Because of the dysplastic valve or the posteriorly placed tricuspid valve, there will be high regurgitation of the tricuspid regurgitation towards the apex of the heart actually. It will reach towards the jetting towards the apex of the heart. But in the tricuspid dysplasia, it will be the midway between the apex and the tricuspid valve actually. So this is the characteristics of the Epstein's anomaly actually. The images are little bit of the in a submarginal way because in SSK Medical College in a very low-end machine this has been diagnosed actually. So we can see the right atrium is enlarged. Actually the ghost scoring is there to know the to actually detect the prognostic scoring of the Epstein's anomaly. Though it is not our work is to actually refer to the pediatrics cardiologist to go for that. It is the division of the right atrial enlargement, the area which is accompanying, divided by the whole 3 segments of the heart that is left behind. So that is going to give you the ghost scoring about the Epstein's anomaly. So even in the fetal period, we can tell this Epstein's anomaly is going to have a cardiac failure later in the postnatal period, or we have to abort this case, or we have to take over this case period of the time. So this is about the case where it is actually it is not a Epstein's anomaly, rather a tricuspid dysplasia. We can see how the right atrial enlargement has happened, but here we cannot see the posteriorly placed tricuspid valve. Rather, we can see these are the thickened the valves, and it is actually properly placed basically. So this is all about that, and we can see the regurgitation of the on the tricuspid valve. We have put a gate on that, and we can see also almost more than 140 the regurgitation, tricuspid regurgitation is happening actually. This is a case of a AVSD unbalanced. This also we can see in the four-chamber view, because in the four-chamber view, except our four segments of the heart, those are the two ventricles and the two atrium, the crux is one of the most important feature. Why? How the crux is formed? Because the crux is formed by the two valves of the segments from the tricuspid valve, as well the segments from the mitral valve, and from the primary septum primum that is hanging from the above, and intraventricular septum. So these four segments are causing a crux. So if the crux is absent, the whole thing is absent. So it is causing atrioventricular septal defect, and it is actually unbalanced atrioseptal ventricular defect, AVSD. We can see why it is unbalanced, because one side is quite larger, the right side, and the left side is quite smaller. So it was a atrioventricular septal defect with the hypoplastic left heart, basically. We can see very well here. So we can see here the Doppler, we can see the left heart is totally diminished with the color Doppler flow. We can see very well. Another case of actually atrioventricular septal defect, it has been 4D. 4D images has been taken, and one is TUI image of the AVSD, and it has been taken. So we can see the crux has been totally absent. There is absence of intraventricular septum. The offsets are actually not in a normal position. The offset is totally diminished. So we can see a long gap. This gap is actually predicting a AVSD, atrioventricular septal defect. And we can see in a TUI vision why it is helping out, because we can see the heart in each segment, how it is happening, how the outflows are coming, how it is behaving. It is almost a single canal defect, so it is showing in this way actually. So this is another case of a single ventricle and single atria, basically. This has been case has been aborted, and we have sent the genetic informations to go for the amniocentesis, and we went for the chromosomal microarray, but it has come to be normal. But we can see here how this heart is behaving. This is one of the rarest thing. We can see there's a single ventricle and the single atria. It is opening to the ventricle, basically. This is one of the characteristics of single ventricle and atria. The single atrium has to open into the single ventricle. Then only it can be called as a single ventricle and single atria. And that is actually causing a single outlet coming from this, this heart, actually. This is one of the rarest heart disease, actually, we have crossed through, basically. You can see one big outlet is coming from the single ventricle and single atria, actually. So this is one of the cardiac tumor case. I'm going to the fetal cardiac tumors. These are also rare variants, actually. We can see this is the fetal cardiac tumor hanging over the left ventricle outside, and we can see the pericardial effusion outside, but structurally the heart was normal. Though structurally the heart was normal, the ventricles, atrium, intraventricular septum, intraatrial septum, the crux, everything were normal, but except the pericardial tumor, which is really, really very big. But I want to comment on one thing. These are coming under late anomalies, actually, we have faced. Maybe they have been referred outside in a very late way. We have diagnosed it around 34 weeks the patients have come, but without any growth retardation of this baby. This cardiac tumor has not affected any functional status of the heart, actually. So we delivered a 2697 gram of the baby, and in SSCM, actually, cardiothoracic unit has resected that tumor and has been diagnosed as the teratoma of the pericardium. This is another case of cardiac tumor, basically, and we can see another thing. It has been diagnosed at around 37 weeks. We can see it in a very good way. It is in the left-sided cardiac tumor, actually. It was really big, and it has caused actually complete arrhythmia with the baby, and the baby died at NICU at the 3rd post-op day, because the massiveness of this cardiac tumor has impacted on the conduction system as well. This is another case showing the cardiac tumor, and we can see the heart has been pushed with this cardiac tumor with the pericardial effusion, actually. But these are my prenatal diagnosis. But one thing I want to comment on this was a case of rhabdomyoma, actually, half. But I have thought of that pericardial tumor with a previous experience, but when I did the neonatal echo at the NICU at our SSCM, I could find the small rhabdomyomas hanging over the ventricles. We can see very well. These are the just like Grapes, it is hanging over all the ventricular wall, we can see. So these are the typicality of these kind of cases. So a postnatal echo with the fetal echo is also necessary to detect, to diagnose fetal heart disease. It has to be also with the postnatal echo. It's a combined effort of a pediatrics cardiologist and fetal medicine always, and with the teamwork we can do the better actually. So another case, those are the decreased right ventricle. In the fourth chamber view also we can see. So hyperplastic right ventricle, or it can be a tricuspid atresia or anything else. So this is, we can see the right heart is smaller than, and if there is an obligatory VSD from the tricuspid atresia, there is an obligatory VSD, and we can see very well the left heart is quite bigger, and there is almost no space in the right ventricle actually. So this is the obligatory VSD that happens due to the tricuspid atresia. The tricuspid atresia usually with obligatory VSD, then the outcome is better. That is the book is saying. And we can see a pulmonary atretic pulmonary we can see with the branches. Pulmonary has got a features from the aorta. Aorta is always a single. The pulmonary is always a branches, like left and right. So that actually give the typical feature of the pulmonary. So we can see it is a pulmonary atresia with the tricuspid atresia with the right hypoplastic heart actually. So it is another case of almost a AVSD associated with the right hypoplastic heart actually. We can see this is the diminished of the right hypoplastic heart, and we can see there is a crux almost absent, and we can see the bigger aorta is coming from the left actually. And we can see a diminished pulmonary artery also. It is almost causing as a single artery. And we will go to the left side hypoplastic basically. So we can see it's a classical case of HLSS, hypoplastic left heart actually. We can see first, in the fourth chamber, we can see this is a bigger right ventricle. There is almost nil left side heart, and there is a pulmonary artery bigger because of the left side is totally diminished. So we can see a aortic atresia beside the pulmonary. This is one of the very important features. If somebody is telling me it is a 3-vessel trachea view is important for this or 4-chamber view this, it's not about that. It's all about the 6 segments. In the 6 segments, we have to see the similar features which has been affected by the organic disease basically. So that's what the very important. We can see the bigger pulmonary and the aortic atresia. So it's a classical case of HLHS with the mitral atresia with the aortic atresia basically. So we'll go to our next case of HLHS. We can see here the heart has been bigger. The cardiomegaly heart is almost in a failed condition basically. We can see the left side heart is totally with no valves, atrioventricular valves we cannot see. There is no blood flow inside actually. So it's a classical case of the HLHS causing almost bigger pulmonary as a single atria, rather playing with a single ventricle pathology, with a not with a biventricle pathology. So this single ventricle pathology has got a very, very poor prognosis later on actually. Whenever it is a biventricle pathology, rather it is much better, but when it is a single ventricle pathology, the picture are very gloomy actually here. Here we can see unbalanced AVSD, another case of unbalanced AVSD. So we can have because this AVSD, VSD, these are very important, rather not going to very big things. Many time these things are also missed because these are actually maybe a sign of Down syndrome later on. I have got a patient with a chronological Down syndrome with the endocardial cushion defect, almost in 2 pregnancies, later on with the 2 siblings. So these things happen. So we have to keep in the mind of the pedigree history as well as the chromosomal aberrations as well as the heart abnormality. Then only we can completely give the good care to the patient. That is one of the crux of the thing actually. It's not always about the cardiac abnormality what we are seeing. What is the picture behind, we have to actually acknowledge the thing. So there is a outlet defects. Outlet defects can have a multiple malformations. We can have a outflow obstructions, or it can have a crossover abnormalities basically. So crossover outflow obstructions, it can be a critical aortic stenosis with the endocardial fibroelastosis, or it can be a transposition of great arteries, or congenital transposition of great arteries, congenitally corrected, and DORB. So we can see these kind of cases. It's a case of critical aortic stenosis. We can see the aorta, the LVOT, left ventricular outflow tract, has been totally ballooning with the valve stenosed basically. So this is why we have to see the thing. Here also we can see after the putting the gate, the pulmonary aortic gradient pressure was almost more than 150. So these are the cases, the critical aortic stenosis, these are also very much rare to find out actually. And these are there is a question actually whether the aortic stenosis develops into the hypoplastic left heart or not, that is a questionable. Or it is a midway between, or how to manage. This can be actually told by the pediatrics cardiologist, basically. So this is, I'm just taking another few minutes. This is the 2 vessels in the 3 vessels. If you are going to the 3 vessel trachea view, we may find out the 3 vessels with the 2 vessels. So we can, it is a case of TGA basically, transposition of the great arteries. We can see the 1 vessels, that is the bigger aorta posing to the anterior to the pulmonary artery and with the SBC and trachea beside. So this is a classical case of TGA basically. We can go through the thing. The pulmonary is coming from the right ventricle and the aorta is coming from the left ventricle, and it is causing a transposition basically. So we can see the whole thing. And this is a classical case of CCTGA basically. No, this is the TGA only. The outletters are showing very beautifully. We can see the pulmonary branching coming from the left ventricle, and the aorta is coming from the right ventricle and showing a parallel circulation. Parallelity with the 2 vessels is the signs of the transpositions basically. So this is a case of a CCTGA basically. Though it is very rare, but I could find out 1 case. Basically the morphological right ventricle will be displaced, and there will be ventricular-arterial discordance as well as arterioventricular discordance, as well as the outflows are.
We do have an Indian study from Amrita Institute by Dr. Krishna Kumar sir. And that study actually showed that the infant mortality in Kerala significantly fell down after neonatal and early infant intervention. So here lies the importance of fetal echo, that if we can correctly diagnose the critical cases of congenital heart disease, then there will be a marked improvement in mortality and morbidity. Congenital heart disease being the commonest congenital defect.